Hi, everyone. I am Barnabas Alayande, and I'm here with Dr. Robert Riviello, and we will be presenting Building Collaborative Partnerships with an Eye Towards Equity. We're both from the University of Global Health Equity and program in Global Surgery, Social Change, Harvard. And I am originally Nigerian, working a lot in Rwanda. We have no financial disclosures. There's a Ugandan proverb that says, if you don't know where you're going, any road will take you there. And so we'd like to start by charting the essence of our presentation. Our learning objectives for today is that we'd like to share frameworks for equitable partnerships that describe an ideal partnership. And then there's specific practices in global surgery that may show that this is a poor collaboration, a poor partnership. But particularly, we're going to focus on partners in low-income settings. And we'd also like to reflect on personal, professional, and institutional relationships. We'd like you also to be able to self-assess, identify shortfalls with equity, and come to terms with the fact that there are structural racism, power imbalances that can permeate these partnership systems. Finally, we would like to encourage you to constructively confront, to humbly allow yourself to be vulnerable and to change practice with sensitive accompaniment. By way of introduction, there is an effect of neocolonialism on healthcare systems and on global surgery. If we look here, we see anesthesiologist density all over the world. You can see the low figures in sub-Saharan Africa. If we take another look at this same map, it reflects colonialism too, because the same countries that we see here that have had low densities are the same countries that were initially colonized. I have something, another map that could show that. But for time, we would look at the evolution of global health, global surgery, and we see that it started with tropical medicine. It was something essentially to protect colonizers. But over time, nomenclature has changed. We've moved to humanitarian medicine, international health, global health. And now we're focusing on decolonizing global health. But we feel that decolonization is strongly hinged on power dynamics, hegemony, dominance, oppression, removal of the colonizer. It paints a picture of an enemy, dismantling a structure, etc. But we'd like rather in partnerships to emphasize not just decolonizing, but equity, which emphasizes access to health, access to education, quality, diversity, inclusion, harmony, and then looks at tomorrow. So when there are two people coming together to move forward an agenda in global surgery or in global health, we have to ask ourselves, what in the world are we getting into? Many of these partnerships are just acquaintances, coordinated efforts, or organizational cooperation. And I love the definition of an acquaintance that says it's someone you know well enough to borrow from, but not well enough to lend to. So there's no mutuality in just this acquaintanceship of organizations, of people, that is sometimes termed a partnership. Is it a collaboration? This may be a bit better because you're working together to produce something. But like a marriage, like a commitment that should be lifelong, few people enter into true partnerships. True partnerships are deliberate and they require commitment. What are the fundamentals of partnership? It's reciprocity. There's bilateral benefit. It is win-win. It doesn't create social structure or power disparity where there are debtors, creditors. It's not a charity. It moves to improve access, moves to improve quality of care and decrease disparities in access to care, strengthen health systems. But we must be careful that we don't, in the name of partnerships, begin to create a new phase of neocolonialism. What then are equitable global surgery partnerships? There are simplistic ways to think about it, and there are really complex ways to think about it. But I think the fishing principle does work real well. You can choose to give a man a fish, right? And then some people say, don't give a man a fish, show him how to fish. But real good partnerships move to the point of finding out if the man wants to fish, and then eventually fishing with him. So there have been Monet principles. In 2021, Monet et al. Did a scoping review of guiding principles that help global surgery or good global surgery research partnerships. And they came up with these findings of mutual benefit, agenda setting together, equity, accountability, capacity building. These are key to good partnerships. There's also the fair trade learning rubric, which establishes that there must be mutuality, common purpose, that there must be leadership by a host program. It's not that some people are parachuting into a country or into where they're having partnerships and then are driving the agenda. The rights of the most vulnerable, even in the partnership, are recognized and deliberately protected. The sourcing of resources is local, it's shared, there's transparency, budgets are not hidden from others. Communication has clear lines of publications are pre-thought. There's recruitment, ethical engagement, literally. And then the theory of change comes for both communities that involve students, that involve people that are involved, comes together. It's accepted, it's welcomed by diverse community stakeholders. It's a partnership, not just a program. Many things that are thought to be partnerships are actually just programs. You see, there's the timelines and commitments extend beyond this single episode. It's something more long-term. And then there's clarity of commitment and clarity of evaluation of partnership success. Another way we can look at it, this may be a bit simplified, but it's an accompaniment model which involves careful planning, looking at local needs, clarity in roles, equity, respect, trust, and mutual benefit for all parties, and then capacity development that does not create dependence. So how do we know that partnerships are inadequate? They may just be driven by high-income countries or by one partner. Is prescriptive. Do this, I've brought the funds for you to get this done, or there may be silos or there are research training programs, surgical interventions that do not address local needs. And there's this concept that one of my mentors calls global health arrogance, the "it's for Africa" syndrome, where there's substandard approaches, extreme focus on task sharing, where there's just gift authorship. We just want somebody from this end of the partnership on our paper so that we don't get flaked on Twitter, or equipment donations, for instance, where it's not just about sharing resources, but a smart way of waste disposal. If you take a look at this common. I've worked with some mission hospitals, with some government hospitals in the global south, and this is all too common. So we must ask ourselves: is this really partnership, or is this an excuse or a hidden way of getting other agendas done in the name of a partnership? I'll hand over to Dr. Robert Riviello.
Thank you, Barnabas. We'd like to share with you a case study of the University of Global Health Equity, where both Barnabas and I have the privilege to work and to be engaged. The University of Global Health Equity is a new university based in rural Rwanda, in this glorious setting under the shadow of the volcanoes. The University of Global Health Equity's task and mission is to create the global leaders of tomorrow by giving doctors, nurses, health managers, social workers, etc., the skills and the tools to be able to deliver high quality care with an eye towards equity, as well as engage in advocacy, policy, and research on this gorgeous campus. The university was chancellored by the late Paul Farmer, who's an inspiration and the vision setter for the university, as well as the organization Partners in Health. This quote from Paul, it really is a guiding for the campus. With rare exceptions, all of your most important achievements on this planet will come from working with others, or, in a word, partnership. UGHE has put a lot of effort into making a lot of partnerships across universities, NGOs, institutions, finding like-minded others with which we can create common cause. And some of those causes are exemplified in the Center for Equity in Global Surgery. CEGS aims to make available for practitioners in the global south, largely in Africa, some of the same opportunities that are available to global northerners, North American, European residents and fellows who are looking to move into the space, into the world of global health. And so we have a 5-pillar program with fellowships, focus on innovation and training, global convenings, and a pillar in research and policy. So some examples of what happens at UGHE, and the partnerships are not just between one university and another university, it's also with the very community that UGHE is based in rural northern Rwanda. There's community-based partnerships so that every student that comes through UGHE receives full ride tuition, if you will, and then there's also a waiver that they sign, a commitment to serve within their communities, whether they're locally or other parts in Rwanda, or for students from outside Rwanda in their home communities, to serve as doctors, as nurses, together with the impoverished, to amplify the healthcare provided there. Other examples of partnerships, we had the opportunity this last fall to work with Duke University and found alignment. Duke was running a course in global surgery, and it aligned very neatly with a Master's in Global Health Delivery program that is already established at UGHE, and we are creating a global surgery option. So in that, we had matched students from 11 Duke students with students from around Africa. Most were from UGHE, but these are master's students, so they themselves were coming from all over the continent, as well as students coming through the West African College of Surgeons, the COSEX of the College of East Central and Southern Africa, the University of Rwanda, from Jos University Teaching Hospital. You can see even the coordinators of the class and the lecturers were from both North America and around Africa. A third initiative is, as I mentioned, the UGHE was really started with this master's program, the Master's in Global Health Delivery, which is part MBA, part MPP, part MPH, and we are creating an option in global surgery, the first of its kind in the region. So when we started, Barnabas said we'd like to reflect and like to give all of ourselves the skills needed and the tools needed to be able to reflect where can partnerships go wrong. And we'd like to offer a few thoughts from our own experiences and from those of our colleagues and our mentors. Some of our missions can send things wrong. A mission to do orthopedic work that then does all the bread and butter cases, leaving all the really hard cases that are difficult and can have complications for the local folks, but displacing the bread and butter stuff from local folks is a way where missions can go wrong. Similarly, we should think about who the patients are we're selecting and who's going to follow up. If we are a global northern program working in a global south situation, are we introducing treatment options, techniques, but not following up with the supply chains for the material needed to do those procedures? And who knows if non-experts are involved, if there is some egregious cases, and don't think anybody in this audience would be doing egregious cases, but of students performing way beyond their scope of practice, or professionals working way outside their scope of practice. That sort of thing can, over time, erode the trust between the partners, but also erode the local patient community's trust in the local professional society. And we should be doing the opposite. Be thoughtful about your photo ops. Your donors and your families want the pictures. Bring the same standard for your photos that you would have at home. There's this quote at the bottom: "The slave ships are back. This time they're with padded cabins." This is from Secretary General of Jos University Teaching Hospital. We need to be careful that we are creating true partnerships of the sort that Barnabas described. And so here's some tips. We're going to mess up. We have to learn how to constructively confront ourselves internally, and then partners, and also be open to being confronted for our behaviors. That's the humble vulnerability, which is necessary for then acknowledging where we've gone wrong and looking for forgiveness. That gives us the opportunity, that building of trust, to accompany, to walk along with our partners, but do it in a sensitive way so that we seek first to understand and then to be understood. That's the sort of partnership building that's going to lead not only to a positive first-time experience, but also ongoing positive experiences that really develop healthcare for the impoverished. which then brings that the emphasis back on the relationships. So another African saying, this one from Kenya: when a man is stung, he doesn't destroy all beehives. One mission might go bad. It doesn't mean you have to destroy the whole thing, but we do need to continue improving. So in conclusion, we think equitable partnerships can be achieved, but it does require mutual dialogue that's based in respect and care, engaging in activities that benefit all parties. That, with the humility, will eventually build trust. That's going to reinforce the good communication practices, allow us to be clear about the roles and expectations of each of the partners, and then be looking towards specific endpoints, not necessarily to end the partnership, but to reassess and to continue. So with that, thank you for your time, and we look forward to any questions.